Good evening, everyone, and I welcome you to the CCOT Specialty Orthopedic Review Course 2017. This is the third time that we are conducting this course at Sir H.N. Reliance Foundation Hospital in Mumbai, and I'm proud and privileged to have so many CCOT members here with me. The first talk of this keynote session is on artificial intelligence and robotics. What does the future hold for medicine? It's a bit unconventional talk for an orthopedic conference, but I'm sure that you will keep hearing these terms, artificial intelligence and robotics, more and more in coming years. And I personally have no doubt that this is going to become an integral part of orthopedics in coming days. I'm a bit awkward giving this talk, as you can see from my body language. And I'll start with this small couplet. जमी पे पाँव है फिर भी आसमान छूने को जी चाहता है हजारों तारों के बीच में एक चांद पाने को जी चाहता है हर पल बदलता रहता है इसका फैसला ना जाने क्या ये दिल चाहता है मीनिंग दैट डिस्पाइट बीइंग firmly grounded we still aim for the moon and amongst hundreds of stars we still aim for that elusive moon and we keep changing our decisions. Someday we want this, and someday this we want this. And while I'm giving this talk, there are a few thoughts that are topmost in my mind. And first of them is, are we too elitist to talk about artificial intelligence and robotics in today's India? When I was preparing this talk, a horrible tragedy was unfolding in Gorakhpur, where a lot of neonates died because of lack of oxygen. And here we are talking about technique and technologies and talking about hand holding the technology, um, whereas we should be holding the real human lives. I also feel a bit awkward because I feel that I, being an organizer, delivering a keynote lecture is a bit unfair. It shows that we are self obsessed. But you'll appreciate that a conference, and you are aware that the theme of this conference is technique and technology. And a course or a conference on technique and technology in today's day and age without a talk on artificial intelligence and orthopedics would be incomplete. I tried contacting many people for this subject of talking about artificial intelligence and robotics in medicine. Unfortunately, I couldn't find a single person willing to deliver this talk. I'm sure there would be many people more willing, more deserving, and of course more talented to deliver this talk. Unfortunately, I couldn't find one. So here I am talking about artificial intelligence and orthopedic despite being an organizer for this case. And thirdly, and most importantly, I know the majority of us here are orthopedic surgeons, is the traditionally intelligent orthopedician is considered an oxymoron. So if you see this Venn diagram, you'll find that uh, people often chide us for having this god complex and having hammer and wanting to help people at the same time. And the orthopedician kind of perfectly fits into all three complexes. And so, an orthopedician talking about intelligence and that too artificial intelligence would perhaps be called as a striking nonsense. Our intelligence is limited, and our artificial intelligence is even more limited to asking Siri whether this is a zebra or a horse. Pun intended. Now, moving over to something more serious, we all know the robots. Robots is derived from a Czech word. It's a biosynthetic machine used for a forced labor. The earliest reference to these were made in Da Vinci's sketchbook, and this helped set up the stage for innovation in this field. Officially, if you look at the history of AI, it was born in 1956 as a both science of engineering and medicine. And these are some old scriptural references to artificial intelligence. Isaac Asimov has this epic book called The Robots of the Dawn, which kind of brought it into the public imaginations. And the Indian mythology has its own share of so-called robots. It's believed that Kumkarna was a robot. So, yeah, so human psychology has always been toying with the ideas of how the robots were, how they will influence the people, how they will destroy the world, and so on and so forth. One of the most important things that had happened was the Da Vinci's. So Da Vinci legacy is what we call in artificial intelligence and robotics led to, I mean, it was in the Renaissance that he made a detailed anatomy of, he did a detailed study of the human anatomy and designed a humanoid robot, at least on the sketchbooks. It was in 1495 and rediscovered in 1950s. And as per the descriptions, the Da Vinci robot called Night Robot was able to stand up, sit down, wave arms, move head and jaw, and could be operated by pulleys and cables. While they by themselves did not kind of progress the science, they provided an inspiration for a generation of robotic researchers, some of whom worked at NASA. Now, just to give an idea of the limitations um, and how it changes, how the AI changes. If you look at this diagram, how many of you here can solve this problem? I'm still counting. I've not got even one hands up. But if you give this problem to a computer, by sheer brute computing force, it would solve a million of such problems in a millionth of a second. Now, see, that's how the brute computational force of computers solves this problem, which to human brain at this stage seems quite extraordinary. Going deeper, the neural networks. So we are all aware of synapse and neurons and dendrites, and an artificial neuron or the underbelly of the artificial intelligence is also in kind of sync with our dendritic structure. So if you look, there are synapses, there are axons, there are dendrites, body, bias, outputs, axons. So the framework of AI is pretty much built on the neuronal structures of a human brain, where it has got interconnections and synapses, a transmission mode, and an output thing. Going more specific, and I'll do this. I just start with the basic things on AI, and then we'll just talk about something of AI in medicine, and then, of course, I will focus primarily on how the AI is transforming the orthopedics. So when you look at the AI in medicine, it's got two branches: virtual and physical. So virtual is about the computational force that I was talking about. So it's basically represented by a machine learning, also called as deep learning, and that mathematical algorithms improve learning through experience in this virtual component of AI. And the physical component are the physical objects, medical devices, and sophisticated robotic arms that actually take part in the delivery of care and in aid in performing the surgeries. So, so there's a lot of talk about what is AI, what is robotics. If we look from an outside, in general, although they are component of AI by itself is the virtual component, is the machine learning component, and the robotics is the physical component. And both of them actually go hand in hand. At the same time, their evolution is slightly different because in robotics, a lot of automation is involved, whereas in the AI or the virtual learning or the machine learning part, a lot of algorithms are involved. Of course, they both need help of each other to kind of progress. Specifically, the physical component, the robots need a lot of inputs from the virtual learning part to kind of perform. And if you look at the learning paradigm for these AI algorithms, they could be unsupervised. They can just go randomly find patterns. It could be supervised. They can classify and predict algorithms based on previous examples. And there could be reinforcement learning. Use sequence of rewards and punishment to form a strategy for operation in a specific problem space. And here at the HN Reliance Foundation Hospital, we are probably the first in the country to start all of our documentation on an EHR format. So this is how AI system for medicine would work. So you'll have inputs from diet, lifestyle, genetics, gut microbiome. You'll have some data coming in from social media, omic data, even wearable technologies. these days, and all of this will be collated at the EHR level. And then there will be precision medicine platform, which can be data shared on a cloud to the researcher and physicians. But more importantly, when it comes to the artificial intelligence and its three component of cognitive computing, deep learning, and machine learning, and the learning paradigms of supervised, unsupervised, or reinforcement learning, that an improved patient care would be delivered. So this is a very important slide because it tells you what data would come in, what all use can be made, and how these three things, cognitive computing, deep learning, and machine learning, would lead to an improvised patient care. So if we work on this template, we'll be able to kind of use the big data in a big way. Now we have a lot of firsts, and we'll keep hearing about these first taste of success in medicine with AI. And first was of course, the protein-protein interaction algorithm that many of you might be knowing, which led to novel therapeutic target discoveries. And it permitted prediction of over 5,000 protein complex, of which over 70% were enriched by last one gene ontology function term. We have got publications, and it ranges from coronary syndromes to pulmonary hypertensions to neurosurgery. So all these sectors virtually have been touched with the AI. And of course, integrating EHR with AI is a big challenge. And you'll see how different things are being working, or different agencies need to work in close collaboration, or a lot of interdisciplinary sharing of thoughts to reach this close coordination between the EHRs and the AIs. This is a video that I've just put to kind of tell you how close we are to the to use of robots in the medicine as well. This is from a car manufacturing plant, Mercedes, of course, which shows the degree of automation that has been reached in the car industry. And this is happening in Germany, of course, but a very similar plant is being kind of being set up not very far from here at Talegaon, I've been informed. And we see that the majority of work in this car plant is now being overtaken by the robot. So it's not just a warning; it's kind of an insight on how the technology is moving forward. We have seen that the car industry used to be a major chunk of employment provider at one stage of human evolution, and today it's been completely replaced with these automated machines, which used to kind of look like a sci-fi film not many years ago. So at least when I was a kid, I could only imagine this happening in some kind of science fiction movie. But this is reality. This is closer than what we know and what we think exists. Coming to more specific surgical robots, and these are the classification of surgical robot. One is the master-slave manipulator, where there is a master, or the surgeon is typically the master, and the robotic arm is the slave, and it's manipulator. And that's how the surgeons manipulate the slave. There are automated machines, collaborative robots, handheld robots, and this is a very interesting notes, which is the natural orifice transluminal endoscopic surgical robots. And we'll just glance through each of these because the talk primarily is about orthopedics. So this is the classical telemanipulator, one of the most successful surgical robots, wherein a surgeon sits on the console and a robotic arm with its camera is operating on the patient. The most useful it has shown, the most of its use has been in the urological surgery and the gynec field, but now increasingly being used in head and neck, cardiothoracic, and almost all oncological surgeries. The traditionally it's called as Da Vinci. It's named after Da Vinci, and over 200,000 surgeries have been conducted in 2016. It's got 4 interactive robotic arms, 3 arms that hold objects, so scissors, scalpel, and electrocautery. And the fourth one that actually carries a camera with dual lens for stereotactic vision. These are controlled from a console which is operator dependent. This is how the arms look like, and you can see all the different type of instrument, and that's the dual camera that we have, and that's the kind of an inside of a one of the arms of the robot. Now, when we look at the evolution of these things, aviation to manufacturing, and now we are talking about orthopedics, that any industry, if you look at the evolution phase, the consideration of industry as an art by experts in field is the first step in the evolution. So people call it, oh, look, the surgery and orthopedics are different. Now, orthopedics is an art; it's a different speciality. We then go into the second stage of evolution where we develop certain set of rules and instruments specific for doing a task. In orthopedics and arthroplasty, we have seen that a certain set of rules and implants have come in. The third stage is where we develop standardized protocols and procedures and templates for doing tasks. And I think we are fairly off that stage. So we have kind of crossed these three stages in orthopedics and medicine. The fourth and the fifth are the eventual evolutionary phases. And you'll see that that's happened to most manufacturing now, where the automation is the buzzword. And now with AI, the AI in the computer integration is the next buzzword. And that's how our industry would also involve the orthopedics and the medicine, wherein we'll go for more and more automation and computer integration. So we'll have less of hard work on the ground and more of hard work behind the scene. So that is where we are headed, and I'm very confident that the pace of this whole development will be very rapid, and before we blink our eyes, we'll be in this automated orthopedics phase. Now, robots in orthopedics have been available clinically in some form for over 2 decades. The first one that was used was Robodoc, and it was a joint collaboration between University of California, Davis, and the IBM Thomas Watson Research Lab in New York. So the development happened between 1986 and to 1992. That's over 25 years now. And the few first again, the Matson described it for total knee surgeries. It was a passive system that positioned saw and drill guides with respect to bone symmetry. Now, if you look at most system now, there'll be a robotic arm, a robotic cutting jigs, or a milling system. And the navigation strategies that will be used will be active, semi-active, or passive control system. Now, there is a difference between the orthopedic robots that from the conventional Da Vinci robot. Well, this Da Vinci would take things out, we put things in, so we kind of implant things, whereas Da Vinci would be typically used to take the prostate out or for an oncological procedures. So there is a difference. And if you look at the basics, what does these robot do? So they confine or they provide more accuracy. So they would restrict a surgeon, for example, not to burr or saw outside a preset volumetric pattern. So a planned level of resection in three-dimensional is calculated, and the robot would restrict a surgeon from doing anything more than that. There will be a haptic sensation mechanism through which an auditory, tactile, or visual change would kind of warn surgeon or would give an idea of where we are going. And this would, of course, mean that we can carry out a surgery more precisely. And various systems have been in use. So if you look at the systems available, there's been Robodoc, which is made by Think Surgical Fremont CA. Then Casper also stands for Computer Assisted Planning and Robotics. Rio, which is the robotic arm interactive ortho system from Stryker. And the Navio PFS, which is from the Blue Belt Technology Plymouth, and now probably bought by Smith and Nephew. Over time, the autonomy and the robotic role has increased from passive to active. So if you look from CyberKnife, Robodoc to Da Vinci, and now even more and more thing. Presently in orthopedics, we use semi-active systems mostly, which is the Mako and the Navio. The original were, however, the active system. So actually, we have stepped right from an active to a semi-active system. So Casper and Robodoc were the first generation ones, which are the active system, whereas the Mako's Rio and the Navio, which are popular nowadays, are semi-active systems. So you can see, and they've got different kinds. So Robodoc was an autonomous system which used milling. It was an open platform and uses CT scan images. Mako again is Mako on the other hand can be used for unicompartmental total hips, total knees. It's a semi-autonomous system, uses burr, reamer, and saw. It's a closed platform for Stryker system. It uses a CT scan. Navio, which I said has been now taken by the Smith and Nephew, is currently approved for unicompartmental, but I hear that the coming weeks we'll have its approval for total knee. Again, a semi-autonomous or a semi-active system uses burr to kind of resect the bone. It's an open platform, so that means it can be used for any uni or total knee systems. Does not require a CT scan. Eye block, personally, I have no experience with eye block. Was being used for total knees, a completely autonomous system, used a manual saw, again closed system, and you did not require a pre-operative imaging. So, so the current system, as I said, are mainly semi-active, and these require surgeon involvement. But they, by providing feedback, which is usually tactile, it augments the surgeon's control and thus improves the safety. They are, of course, will have a haptic system or a haptic mode to kind of give feedback. And a lot of people would say, what is different about this from computer navigation? So, computer navigation have been typically a passive system. They'll just give you a guidance and feedback, but they'll not block you. They'll not provide a haptic restraint from overcutting or under resecting or going out of a particular area. So, the robot is an enhancement of navigation in terms that not only it does tell you what to cut or what not to cut, it kind of makes sure that you do that particular thing. So so that is semi-active, and over the years we'll probably have an active where we will not be actually performing the surgery at all. As I said, it's a step back because the original Robodoc and Casper were an active system, but for some reason their success rate could not translate into actual benefits, and hence the semi-active robot system, wherein the involvement of surgeons are equally necessary, have come into play. Now, when we look at how we do it, there are three steps: pre-operative preparation, operating room settings, and technique or execution of the procedure. And here I'll talk about Blue Belt Navio, which I'm familiar with. It's an image-free system, so that means no CT scan is required. It takes all the data intraoperatively by registration or mapping and causes planning. It does an intraoperative gap balancing. It's a semi-autonomous system, and again, it uses burr, which has got two mode: a speed control and an exposure control. So these are the two mode that is used. Two main inventories. So we've got a pre-operative planning workstation, and then we have got an arm. So if you look at the whole thing, just two main hardwares are there, which is a working station and the other is the electromechanical arm. Pre-operatively, we sometimes require a long leg X-ray, and if required, CT scan for assessment of bone and deformity. So the system doesn't mandate taking a CT scan, but if you wanted to kind of understand the anatomy better, you can use that. So the referencing is just like conventional navigation, and the steps, of course, are again simple and similar. Which is the first step is the registration, the second is the gap planning, third is the prosthesis placement planning, then carrying out the resection or burring, and finally the validation. So this is the workstation, and that's the robotic arm. So first step, as I said, is the placement of array. Usually, if it's a unicompartmental replacement, you can place the array very close to the medial femoral condyle. So you can see the placement, and that's the registration happening. So the registration device is pretty similar to the conventional navigation. You do the femoral registration by rotating the center of hip in various direction to kind of pinpoint the center of hip. You map the femur and tibia, and then you can plan your gaps and processes placement. This is typically the burr. It kind of moves in and out of this whole thing, and you can see how it burrs. So if you look at this pink area, that's the area that is supposed to be burred. The yellow is that you have reached a level which is not adequate, but you have burred that area. And the green stands for the area that has been burred enough. So suppose burring, this is how with the pegs the femoral bone looks like. So on the left hand of your screen, that's the typical burring process, whereas on the right side you see the tibial on the top, and then you see a prepared femur. And I'll run a small short video of showing how it actually happens. So this is the company video by Blue Belt Technology. You can see the femur being registered. the gap being balanced now. And this is the handled robot. You can see that the burr is coming in and out, and all those trackers are there. So it is burying the bone now. It's similar to the other video where you can see actually the burying process that's happening. So you can see that I'm just holding this where and the whole thing was kind of a haptic, providing a haptic sensation by the sound and this whole thing. It's been used in spine. So again, it's called as Medor Spine Assist. Different attachment point on each mount, three different drill guide lengths, and two extension bridges. And of course, the software can be used in conjunction with the plan and inform the surgeon about which position drill guide and if any extension bridge will be needed to place the implant. So the spine people have also started using it very. I'll not call it very frequently, but yes, we can see things happening in the spine arena as well. Outcome studies have started coming in, which is a good thing. That means that people are using it and validating their outcomes with use of these devices, and so far it doesn't look too bad. Okay. Now, this is the buzzword for whom the bell tolls. Now, people are scared of the technology. People That's happened when the computer came in, where people believe the computers will take away the jobs. And now the next thing is the AI. So everyone is worried that artificial intelligence will kind of steal away the jobs and probably we'll be redundant as a human race. So I can only tell that I don't know. I don't know the answer whether it will be good, bad, or ugly with the AI and robotics coming in. I can only tell that it's imminent. But there are some insights on what will happen to certain things. So this is an example where the computer defeated the the chess master. Okay, and so if you look at the games like chess, Jeopardy, and Joker, of course the computer has shown that it can defeat humans. So as I said, anywhere where the sheer computing force is required, computers are definitely going to take over, and they will be much better than what any human can ever think or do in terms of performing on a computational power. So all these things where a lot of moves are involved, where a lot of thinking is involved, the computers will take over. But you'll not see it in the field where more skillful things are required. For example, golf. No one talks about robots in golf. So if you look at the real story, they robots fall over opening doors. Their intelligence is less than sixth grade. For example, they kind of commit stupid mistakes. So for yellow and black stripes can be mistaken for a school bus. And in life is very complex. The other side of philosophy says that the vision, illusion, confusion, and and rarely conclusion. That's what makes us human. That's current state of human civilization. That there are no fixed answers for things. And the true sign of intelligence is not knowledge but imagination. And robots do not have an imagination. So I think human will have some role. It will ensure that some things are being taken away from the human beings. But as long as we are creative, as long as we are imaginative, I don't think the robots will take over the entire human civilization. As a surgeon, we have got uh, different stages of uh, our career. We start from general knowledge, acquire some basic skill. We start with assisting, then become a training surgeon. We receive our board certification. We practice, and then we have a mastery. So the debate between a born surgeon and cultivated surgeon is, I think, somewhat outdated. I think we'll be increasingly leveraging technology and techniques to reinforce our skills, and they'll become an important part of our armamentarium to perform complex surgical procedures. When you look at the road ahead, it's unclear. We have got two of the topmost mind in the field of technology clashing over the future of AI. People predict doomsday scenario. People can accuse other of having a limited understanding, and good enough that we've started having editorial discussing the rise of artificial intelligence and uncertain future of physicians. So yeah, so there's a lot of uncertainty around. But in a nutshell, I can only tell that no industry which has seen robotic being introduced has not seen an increase in production capacity, improved accuracy and precision, along with lower cost. So now that robots are being introduced in medicine, I'm sure that these things will happen, that eventually it will be used more and more to improve our operating capabilities, improving our accuracy, our precision, and decreasing cost. There are periods of development and refinement before the adoption happen, and which is again where we are in today. For me, being an arthroplasty surgeon, I think it is definitely going to lead to a viable improvements over time, and that these failed technologies will prove to be a stepping stone for very exciting future development. This talk was titled "What Does the Future Hold?" And as I said, I don't know what the future holds, but I do know who holds the future, and the answer to that is us. I think the best way to predict the future is to create it. I think all of us sitting here as an orthopedic surgeon, as a member of CCOT, as a member of Reliance family, have capabilities, have vision, have desire to create something which is long lasting. I think this is one arena which requires a lot of work, has got a lot of scope, it's got a lot of imagination, a lot of things that we can contribute to the society. And I think it is for us to create the future that we want. Thank you very much. And once again, um, I welcome you again to this evening of CCOT keynote lecture session, which will be followed by the dinner. Uh, um, as a host, I would also like to introduce my next speaker, Dr. Clement Joseph, who is going to talk about a very interesting topic on the regenerative medicine. So you look that we talked about the artificial intelligence. Now we've got someone who is pioneer in the field of regenerative medicine, talking about where the other future holds on the regenerative medicine. And then we have got a professor from IIT who's going to tell about the implants and the bioimplants. And finally, the most important, the human aspect. The fourth lecture on the today's night is about teamwork. So I think unless the teamwork complements the technique and technology, nothing can move ahead. So we've got very interesting lineup of lectures after this. So kindly stay on, and followed by all these lectures is an equally interesting dinner which our chefs at Reliance have cooked up using the technology. So you'll have some unique things. I'll not disclose the secret, but I'll just give you a glimpse on what you can expect. You'll have beetroot blood shots in test tubes. You'll have smoking things coming out. So it's molecular gastronomics and technique and technology in food industry that will be at display. So stay back and enjoy the evening. Thank you very much. May I invite Dr. Clement Joseph to take the stage.